Are you ready to revolutionize your understanding of healing? I'm Dr. Tammy Penhollow, a spine and joint specialist. Today, we're diving into the cutting edge world of regenerative medicine with Ryan Martin, PT, DPT, a leading expert teacher and practitioner in musculoskeletal ultrasound diagnosis. If you've ever struggled with a musculoskeletal condition, just how vital accurate diagnosis and effective treatment are. Join us as we explore why ultrasound isn't just a tool, but it's a game changer for both precise injections and thorough assessments. We'll share how ultrasound enhances the diagnostic process, allowing for real-time imaging that helps identify injuries, monitor healing, and tailor treatments to individual needs. For patients, this means more personalized care. This means reduced risk of complications and improved outcomes. Whether you're a healthcare professional or someone navigating the challenges of pain and injury, you don't want to miss this enlightening conversation about the invaluable role of musculoskeletal ultrasound in modern medicine. Ryan, welcome. I'm so thrilled to have you here, and I know it's taken a little coordination of our schedules. It is far worth the wait. Bring it on.
Excellent. Well, I know we've been going back and forth to try and set something up for a while, so I really appreciate being on this show, and I appreciate everything that you're doing.
It's my pleasure. I am so excited to share this, not just for patients who are navigating this, but also you reach a much broader audience. You train physical therapists. You train physicians like me. You've trained me in musculoskeletal ultrasound. So what's the big hype about ultrasound? Why?
Why ultrasound? Well, I mean, it's been around for a long time, and we've heard it from so many various aspects, from OBGYN, thyroid, kidneys, everything. And so now the pioneers of MSK ultrasound, we're starting to see new light on literature and data and more clinics using it. So why use it? It's because it works.
It does. It works at the initial consultation. It works in follow-ups to physical rehab. It works in follow-ups to something that I do with ultrasound guided injections. And obviously I use them for the injections. So do you have stats regarding that? Do you have like where it's most likely to be used in a physician's office versus in a physical therapist's office, and how you and I coordinate care of patients knowing that?
Well, right. I mean, MSK ultrasound is a tool that can be used by so many different professions and different settings. For example, in physical therapy, if there's a trained physical therapist, it's a great tool for getting diagnostics right away. And then understanding the tissue, the properties, what's going on can help kind of guide and lead us towards a different plan of care. But what I always tell people, especially in the PT realm, or if you're in sports medicine or anything, is your evaluation is paramount. Getting your history, taking all the information, your special testing, getting the right diagnosis and what you have in your mind first is so important before even putting the tool on there. And so once you have a running diagnosis and you get confirmation or even denial of what you thought you may have had, or even differentiation of how severe you may have thought it was, from that point, you can decide an algorithm of treatment in your plan of care. And so from a physical therapy perspective, do you keep them in-house with conservative care based on what you saw? Do you then refer to a specialist such as yourself that has other tools that you can utilize to help with this patient's care? Or do you look at this and say, this is something way out of here? Do we have another specialist like a surgeon in mind if you have like a full thickness rotator cuff tear and it meets the criteria of a tear or something like that? So it helps build the algorithm in all these clinical settings. And then in our practice, we have both physical therapists and medical providers working in tandem. And so we can actually just work that into a single groove. So everything's all in line in under one roof. And so we use that entire algorithm to help our treatment protocols and help with patient care.
I love that. It's added so much more depth to the algorithm, honestly. Like you said, you get that history, you do an inspection without even touching, then you touch with hands, do specific special tests for a joint. For example, in a knee, we've got something that looks for an anterior or posterior cruciate ligament. We've got something that looks for the collateral ligaments. We've got something that looks for the meniscus. Let's just say, based on the history and the inspection and the palpation and this original stuff, I am suspicious for maybe a meniscus tear, but they're not positive on a special test like the McMurray. But then I put the ultrasound probe on and I can see it. What are some of the reasons, like with the patient's anatomy, with the patient's musculature, with whatever, that would limit my physical exam that's then uncovered with the ultrasound exam?
So during our examinations, we know sensitivity, specificity. You probably know me long enough to know that I'm a huge nerd. And so we know that some of these tests are not infallible. They're not perfect all the time. And so sometimes we'll miss something on a McMurray click or a Thesleys or something of that sort. And then you go and you put the ultrasound on there. And remembering the limitation, one of the main limitations of ultrasound is you cannot see past cortical bone. And so you can't see intra-articular, but if you have peripheral tears or if you have secondary signs of meniscal pathology, it'll be pretty clear that you'll see that. So it's pretty evident when you see peripheral tears or secondary signs that you may have missed during your examination. And it gives you another idea of, all right, is this a candidate for the next step in care, whether that may be a specialist. From a physical therapist perspective, is it a specialist or do we go conservatively? When talking about patients' anatomy, we do know that looking at the ultrasound, there are clear markers for, say, and again, we're talking a lot about the meniscus. If you have extruded tissue coming out of that joint line, something's wrong. If you see a lot of mobility with dynamic testing, which you can't necessarily get with X-ray or MRI, so if you understand your testing properties like Barrett's valgus stress testing, extension testing, things like that, you can test this right with the ultrasound and see if it's extruding, or if you have these what they call hypoechoic clefts or tears through there, you can pick them up pretty readily.
Right. I completely agree. And you've added in something that at a level, when you're laying in an laying in an MRI scanner, or you're standing for plain films, first of all, we know the limitations of plain films. It shows bone and air. It shows joint space narrowing or no narrowing. And an MRI is beautiful for all that soft tissue, but it's a static exam. Can you differentiate for the patient what is a dynamic exam and kind of expand upon what you just talked about with doing stressing? Does that mean the probe's on it at the same time?
Yeah. Okay. So this blew my mind when I first started this. Is think about going into your physician says, all right, I want to get an X-ray, I want to get an MRI, and you go to the imaging center. That's another whole story we can talk about, is doing in-house versus referring out. But you go to this imaging center and they put you in a tube or they lay you on a table. And what's the first thing they always say? Don't move, right? Because it's static. It's an immobile picture. It doesn't give us any more information than what you see statically. In MSK ultrasound, the point of this is you can take static pictures with MSK ultrasound, but on top of that, you can get the body moving. For example, if I thought I had a supraspinatus tear, which is a rotator cuff muscle that helps with abduction, if I looked at that tissue and statically it looked pretty normal, the fibers are intact and I don't see any irregular tissue context here. And then I say, hey, while I have the probe on, so this is during the procedure or during the intervention here, is during the diagnostics here, I'm just going to have you do certain motions or push into your arm and see if that tissue actually changes properties, if those fibrillar patterns separate, or if you have what they call paradoxical motion, whereas the bone goes one way, the tendon goes the other. That's not right. And so when we see all of this, we have a better examination and idea. All right, we thought statically, this looked pretty stable. But dynamically, we have a whole different story. And it now changes my plan of care.
Completely changes the plan of care. And that's why sometimes people say to me, but my MR is normal. Are you making stuff up on this ultrasound? What are you talking about? They didn't read that on MRI. So what are you talking about? And that's where we dive into this, that we're doing a dynamic exam with the probe on, and you can sometimes suss this out.
Absolutely. And there have been cases where the MRI did come back with a negative testing. And then with dynamic evaluation, we looked at it and you saw clear what they call herniation of the deltoid bursa, the subacromial subdeltoid bursa. So you saw clear signs of this tissue being separated out with fluid coming through that area, which is not a normal finding. And so when you present that and you discuss that with your team and or other referrals out there, usually if you have good communication with that referral, they'll understand, okay, I see what's going on.
Right. Similarly, I know you don't do injections, but you are there for the diagnosis with the ultrasound, and you can sometimes have a mild, what you think is mild tear on an MRI, but once you actually get the needle in there and you start injecting, you can see it all of a sudden balloons up or tracks a lot faster, further than you would think, and it's more severe tear than you thought even on MRI. very similarly, but you're seeing it with the ultrasound as you're injecting.
It's funny is this just happened last week. We saw a small articular surface fraying of a cuff tear. And once the injectate was actually applied, happened to be PRP at this time, but once the injectate was applied, you actually saw the fibers completely separate, leaving some trail of the bursal sided. But as you saw it fill up, we realized, okay, this was a little bit bigger than we suspected.
And then how would that change the management from the physical therapist side? Obviously, it changes the management from the physician side, the sports med doc, the regenerative med doc, or even the orthopedic surgeon. But how's it change your management as the physical therapist?
From a physical therapist, because these injections are obviously done with the physicians that are in-house, we have a collaborative talk on not just their pain levels, not just their function, but how do they feel? And so we have to take so many variables into consideration is after we've done something like that and we do see a full thickness tear, if it's something that we feel is not going to be able to be managed within our scope or within our practice, we have referral sources to orthopedic surgeons that can get that secondary consult. There's no reason for us to try and conservatively manage it if the patient's unable to function with that and is still having pain. So yeah, it will change the plan of care. Rarely do we see stuff like that, but it was something more recent that we did notice. The patient did have successful treatment in that, but again, we have to wait a couple more weeks to see how they're really doing. But we do have an orthopedic surgeon on the back end in case it's not successful.
I love that collaboration from diagnosis all the way through to a definitive treatment. And then when the person has something like a surgery and they come back to you for the rehabilitation, do you use ultrasound in that management of them along your protocol as well?
Yes and no. Typically, no. So if it's been post-op, so if it's status post for anything, again, we've been talking a little bit about the rotator cuff, so I'll just kind of maintain that. So if it's a supraspinatus repair, and they're doing fine, chances are we're not going to be taking any imaging of that during the treatment process. However, say patient falls or runs into something or has an incident of some way, shape, or form and felt something in that shoulder and it has changed their progress. Well, then we have to consider, all right, what happened to those sutures, those anchors? What's going on with that tissue integrity? Usually at that point, we'll call the surgeon, make sure we're all on board on the same page, making sure that we're not stepping on any toes. But we'll make sure we confirm, all right, hey, this is what happened with the patient that had surgery. Would you like to go ahead and have us take a look at those sutures and anchors on ultrasound? Because if anybody's ever looked at a post-op shoulder, a rotator cuff repair, it looks like somebody threw a grenade in there, and it's just this potpourri of mess in there. So even though it could be completely repaired and fine, that MRI might miss it just because of the mess that you see post-operatively. Whereas the resolution on an ultrasound, it doesn't pick up that same artifact.
Absolutely. Then we talk about the limitations of MRI with metal. It almost looks like there's star bursts everywhere around the metal, and that might be right there in the space where you're looking and saying, is that where there's a tear again? Is that where we've had something pop off? And you don't know because of the artifact. It's called artifact from a radiology standpoint. So I love that you can do that, and you're not waiting for another MR, or the MR could be inconclusive as a result of said artifact, but you're able to do it right then and there in their rehabilitation session. How special is that for a patient?
Here's the thing. If you want to talk about know, like, and trust, I mean, we've heard all these terms before, but if you want to build trust with your patient and you're able to give them a definitive diagnosis and a treatment algorithm based on that diagnosis, they're a patient forever. I mean, there's no ifs, ands, or buts about it. They're a patient forever.
I agree. I love being able to show pre and post images, and you can on the ultrasound machine I have, and you've got them cataloged about the date when they came in for a consultation, the date when they're now 8 weeks after PRP to their knee, for example, and we can look at the medial meniscus, which had a nice fissure along the area and a lot of swelling around, and we can compare them side by side, and the patient can see that. I don't expect them to read ultrasound images, but they can see things like big fluffiness or dark blobs of fluid or whatever. They can see that there's not a vertical cleft anymore. That, I think, helps them understand, because there's only so much I can do with the plastic knee model, actually showing them on their own body right then and there.
Yeah, absolutely. I mean, we understand that the communication and the language we use is different with patients. I like the fluffy, look at this cloudy appearance. Look at these fibers. Do they look like guitar strings to you? Oh, yeah, yeah. Okay, now look on your other leg. See how they don't look like guitar strings to you? That goes a long way with patients. And they don't have to necessarily understand how to read ultrasound, but they can compare what looks good, what doesn't, and how things have changed with your plan of care.
I agree. I think it does help build the trust and then just understanding. As me as a patient, I want to understand what it is and then what our target is. So can you break it down? Some people are saying, yeah, this is nice. It's cool. I love tech, but do I really need this? I've got an orthopedic surgeon who's been giving me my the HA, the hyaluronic acid, into my knee for the past every couple of years after the 3-shot series. And I know that sometimes they work and sometimes they don't, but he's done tens of thousands of injections. I'm not going to try to pick on a surgeon, but let's do it right now. Tens of thousands of injections. How do I know that he's actually getting this product into my actual joint? Are there some stats out there?
Well, absolutely. I mean, empirical data is something that physicians, PTs, healthcare providers, we rely on it. We shouldn't be overly reliant on it. I think that there's other variables in play, like clinical experience, things like that. But we do need data to understand where we are. When we're talking about what we call blind, or we'll call a landmark injection, when you're talking about that versus an ultrasound guided injection, there's plenty of studies out there to help validate the use of MSK ultrasound in a clinic. Everything from shoulders to knees to hips. I mean, those seem to be like the biggest ones that people are doing research on, but I have data for ankles, for carpal tunnel, for all sorts of things. I mean, even the knee alone, I think that's probably one of the biggest case studies and literature topics out there is the knee, because it's such a prevalent pathology, is knee arthritis or knee pathologies out there. So, I mean, I've got pages and pages of data, but I mean, I think it's just easier to just break down a couple quick numbers. Like Feng et al. In 2021 did a huge level 1 only research study over 1,300 knees, finding with the accuracy of MSK ultrasound versus palpation and blind injections. And MSK ultrasound was anywhere from 95 to 100% across the board. And then with palpation or blind, could it be anywhere from 77, 79%. So that within itself, here's the thing is, do you want to be in that 20% of cases that missed the mark versus something that's so easy to do to get anywhere up to 97 to 100%. And I highly recommend, if there's any interventionalists out there, get Malenga's book, The Atlas of Musculoskeletal Ultrasound Injections. And within his book, he has tables of literature that show everything from MSK ultrasound guided injections to landmark injections. And they even compare it to fluoro. So if there's people out there and says, well, I have fluoro, I can do everything. There's some things in there that are missed in that. So, I mean, even in, again, with the glenohumeral joint, 95% success rate. So in the glenohumeral joint is 95% success rate, whereas with palpation was 79. Now, these are coming from Malenga. The ACJ, so the acromioclavicular joint, 100% with ultrasound. Here's one for you. Palpation, you think where that AC joint is? 40%. 40.
Yeah. You think it's
That's
so
tough to
tiny,
hear.
and I can absolutely feel it, right? It's just right there. It's so superficial. 40% versus 100%.
That's insane. And then even with the knee from Malenga, he had multiple studies, 99% ultrasound to 79 palpation, 100%. Oh, this one's crazy. 100% to 55%. Okay, so I mean, the studies keep going on and on and on. And then the one I love the most, and I always tell this when I lecture, especially with the knee, let me set my stats down. So the one I love the most is Pez and Serene. And I have plenty of stories about this. The Pez and Serene, you can touch it, you can feel it. It's on that anterior component of the knee right there. Or it is, you can feel it. You're like, I'm on the Pez and Serene. Okay, ultrasound guided, 100%. Now, palpation skills, 17. 17.
1-7.
1-7. Yeah. So, I mean, again, this is the literature to help support using MSK ultrasound, but the caveat is know what you're doing. Don't just pick up an ultrasound and think, all right, I'm going to be able to do this. There is an education component to it, which you're well aware of.
There is. So from a patient standpoint, you're looking to find somebody who uses ultrasound diagnosis and ultrasound guided injections. Those are two completely different things unless you're going to somebody who can do both things end to end, right? So how does a patient, when they're looking around, calling around, how do they even know what questions to ask, saying, what, do you use ultrasound? And then knowing that the answer could be, yeah, I place it right here. I put a little mark on it, I put it off, and then the needle goes in there. That might have been ultrasound localization, but it's certainly not ultrasound guided to see point to point every single millimeter, avoiding said nerves, arteries, veins. all these things you don't want to blow up with the needle. So how does a patient approach this?
That's a tough question because a physician can say, I do ultrasound guided. I guess what the big thing would be is look at the reviews, see what people are asking. And you could even ask, I mean, as a patient, you can say, does the ultrasound stay on the entire time? Don't blatantly act, like try and call them out, but like, hey, I have a question because you may not know. Does that ultrasound stay on there the whole time the needle's on there? Very inquisitive like. And find out what are those answers to that. And if they say absolutely, well then yeah, they're probably doing a guided versus a target area and then still doing a landmark injection.
Right.
Have I seen that? No, I haven't seen it in many, many years. I feel like people have really gained a lot of confidence in learning how to do this and understanding the value with it. So I think those days, I don't think they're long gone, but I think we're getting out of that.
So right now you think that there's 100% landmark or palpation to 100% ultrasound. We know that there are neither of those, but there's a little bit less in the middle where you might have identified, marked it, taked it off. So we're either one of these, right? Based on
Yeah,
what
I
kind of
feel
clinic
like
you go to.
Yeah, because I feel like if you're going to get an ultrasound in your clinic at this stage, because I don't want to just say social media, but education wise has been so expanded in the field in the past decade, is that people are realizing that that's not the right way to do it. And then you're also seeing these people that are doing landmark and they are starting to transition into MSK ultrasound. So again, the field is changing radically and it's only for the better based on the data that I presented.
So you've talked about you've given these amazing stats that some of them blow me away. It's just unbelievable because you think that you could get it into there. So obviously accuracy is one thing that you can say, I'm paying X number of dollars for my own blood, bone marrow, adipose to be placed into this target, which we're finding this region of targets. We kind of treat a whole entire ecosystem, not just the glenohumeral joint, but often the tendons, the ligaments, all those things. But let's just say I'm paying cash for this. I want it to be accurately delivered to the target. What are some of the other benefits in terms of risk mitigation, not getting the bad guys? What other benefits, not just that you're getting it accurately delivered to the right place?
So, what other benefits of using ultrasound? I mean, if you get it into the right place, so if there is accuracy, there is also data to show that patient satisfaction and objective pain scales and range of motion, active, those all improve as well. So, not are you just getting to the right place, you're actually making improvements in their quality of life because you're more accurate. Does that kind of answer your question?
Yeah, the outcomes. And there we're
The
collecting data.
outcomes.
The outcomes are better. And are we avoiding things like not putting it into the vessel? And granted, you end up putting a platelet-rich plasma into a vessel. It's not like the heart have any major harm because it's your own blood into your own bloodstream. But who wants it there? Because then it's going to be taken into the circulation and wiped away. But you are avoiding needle trauma to a vessel, needle trauma to a nerve, needle trauma to a place that doesn't need to have a needle in it.
Yeah, I mean, on the flip side of getting to the right place, it's just as bad. It's sometimes even worse putting in the wrong place. The repercussions of putting an injectate or a needle in the wrong place. And again, I have carpal tunnel studies that are showing blind injections versus ultrasound guided. You imagine if you penetrate that nerve, what could possibly happen? Now, I know there's going to be a lot of people out there that say, well, I've done 1,000 of them and my success rate is XYZ. That's great. But it's what Don Buford says is putting ultrasound on there is not going to make you worse.
Right. So say I'm sold on it. I'm a patient and I know that I want to have. So I'm going to ask the questions like you said, and I'm going to kind of look at the reviews and I'm going to say, what kind of training did you have? And say I'm satisfied there. Well, then that puts a little bit of a good, I think, pressure on advancing the field. And I'm a physical therapist or I'm a physician. What kind of a learning curve is involved? What kind of things are involved? I know you can't go into the huge details about it, but what would it entail and about how many hours? And is there continuing education? Kind of what would it entail for me to jump in? I'm ready.
So you're a physician or a PT that's come in and you don't know anything about ultrasound. One of the big downsides of ultrasound is the learning curve.
Mhm.
It's a very steep learning curve, but once you understand it, it actually gets really smooth. So when you talk about time frames, everybody's a little bit different, mainly because of how do you comprehend looking at three-dimensional anatomy and putting it into a two-dimensional slice at 2 millimeter slice, black and white grayscale versus color. So there's a lot of things that go into, all right, how do you comprehend that versus how much time and effort do you have to put into this, right? So if you're going to be studying weekly or if you're going to be studying daily, whatever it may be, but there's programs out there to where you can study consistently and have a really good idea of what you're doing within a couple months. That doesn't make you an expert in any way, shape, or form, but you can get going and understand clinical reasoning skills are there, then understanding that the ultrasound is going to coincide with that. So again, time frames can go anywhere from a couple months to a year. It depends on how you're spreading it out. And it really comes down to your dedication to learning. What is it that you want to accomplish with this? If you want to just play around with it, I'm not a big fan of that. If you want to take some weekend courses, that's cool, but usually for refinement of a skill set or to get motivated to do more. So I think this is one of those skill sets where you really have to dive in pretty deep if you want to get really good at it. And I think even if you're doing interventional, and I use like, oh, I don't need to learn how to diagnose. I don't need that. And I just want to stick needles in. I want to see where to go. Here's the thing. If you understand the diagnostic properties of this and tissue qualities, histology, the physics, if you understand all the things that some of these programs are teaching out there, it's going to make you that much better of an interventionalist. So if you understand the back end of the diagnostic process, that's going to make you even better.
I love that. Yeah, because as we talked about, the physical therapist isn't the one putting the needle in the place, but they are the one who maybe has done the diagnosis, and then they can be there at the time of the intervention and help with probe placement, etc. But absolutely, there's beneficial to both sets of medical practitioners upping their game and advancing with this technology.
Oh, absolutely. I think interventionalists should at least have a solid foundation and running knowledge of the diagnostic side of it if they're going to be doing interventional under ultrasound guided injections.
You said there are training things. I know that you happen to have little knowledge in that. Go ahead and say that. We haven't really dove into what you do, what your story is. Now I think is a perfect time to showcase that.
Well, again, by education, I am a physical therapist, but the daily operations of things, I was getting burned out, just like everybody hears that story, right? And so an opportunity presented itself to do a mentorship with sports med physicians and learn MSK ultrasound. So I spent a couple of years just working side by side physicians, understanding their thought process and doing ultrasounds day in and day out. I mean, 20, 30 scans a week and understanding it, just being in the trenches. And so that's where I really got my knowledge base and harnessed that. And then I took the RMSK exam, which is the Registry for Musculoskeletal Ultrasound board certification. And then from that point, just developed an education program because I felt that it is so important for people to understand that this isn't a toy. And if you don't understand it the right way, there's repercussions. And it's what my dad used to always tell me as a kid is be careful of shiny toys because sometimes they have sharp edges. And so in the case of MSK ultrasound, we understand that, yeah, this is a great tool, but if you're wielding it incorrectly, the repercussions are on the patient's side. And we never want to go down that pathway.
So you actually train physical therapists, you train doctors. What was your target audience?
My target audience is yes. In a blanket statement, yes. We do treat, so we have both an online program that you can go in and learn the didactics with videos, all that kind of stuff. But we also host a residency, which is a year-long residency where we have in-house training, virtual training. We do weekly calls. So, I mean, it's very in-depth. And so we train everything from physical therapists and physicians. So within our residency, we have all of them actually in the residency collaborating, which within itself is pretty interesting to see how each category of healthcare practitioner is interacting with each other and learning from each other on each session. And so we have docs fly in from all over the country to shadow within our clinics. I'm also a partner in 6 clinics in Phoenix. They come and get to shadow at those clinics. And then we also have physicians outside of our clinics that host residents as well for learning modules. So these are, to me, and of course I'm biased, I think this is the right way to train people. I think this is the right way to do this in the benefit of the patients and for the future of healthcare is making sure that we're not going down the wrong pathways of education. Now, there are other education systems and programs out there. I think there's a lot of really good ones. So, but I do think that if you're going to go down this pathway, and I hate to stand on a soapbox here, but if you're going to go down that pathway, due diligence and do some research to understand what you're getting into.
Couldn't have said it better. And it's fascinating that you have developed this over these time and that there's that integration, because that's ultimately what you're doing anyway. If you are not the perfect diagnostician as the physician, you have whatever kind of a lineup you have due to your medical practice model, that you can't spend the time to do that ultrasound diagnosis for some reason, that you can have a great collaboration with a physical therapist who can dive in above and beyond and get you that diagnosis. And then they come back to you and you have the knowledge to then appropriately place things in the right target and not into the wrong targets. I just love that you're doing side-by-side learning. I can't see where it wouldn't work that way.
Absolutely. And here's the thing though, is communication, as with anything, talking to patients, talking to, I don't know, a salesperson at the car dealership or whatever, communication is key. It's paramount. And when you have an integrative team with physical therapists and physicians all in one or in tandem, integrating that system all comes down to the communication lines and having a systematic approach on how you handle each case. And so before that patient even comes in the door, there's already a system in place on how, like, all right, this patient comes in, where do we go and how does that happen? So there's no communication breakdown. For one, it looks confusing in the clinic. And two, the patient doesn't want to do that. And three, you're going to get bad outcomes. So to your point, is it a good model to have an integrated system? Yeah, if you can have it under one roof, absolutely. But if you can't even have it under one roof, I think it's great for physicians to reach out to local PTs that may be doing this and build that rapport, seeing how good they are. Spend some time with each other, so what the quality is coming out of it, and build that rapport. Even if it's in a system outside of your personal clinic, at least that collaboration is there. But in my opinion, again, a little biased, but in my opinion, under one roof works so seamlessly.
The patient's right there. You can go outside, maybe take a second to pull out of the other room, but you come right then and there and see, this is what we're finding. And it's, yeah, the patient is there in one visit.
Yeah, absolutely.
Fantastic. So do you see limitations of ultrasound? I mean, we've talked about the good. I just want to bring it back around and in full disclosure, what are some limitations of ultrasound?
I think that's fair. Because again, a lot of people out there think that they can just get at this right away. So number one is the learning curve, which we talked about. That's kind of a huge turnoff to a lot of people because they don't have the time or energy. But with the right resources, that can be mitigated. Number two, some of the limitations of the physical attributes of imaging is you can't see past cortical bone. So if you're looking for certain interarticular pathologies, may not be the best for you. Another one is going to be cost. Like, oh, how much am I going to have to pay for this? Or what am I going to have to do? What's the reimbursement rates? And so you can get into MSK ultrasound relatively affordable. You can get into MSK ultrasound both from a diagnostic and interventional perspective pretty cheap, but you do get what you pay for. So that's one of the big limitations is time and money is the biggest ones. And then of course, from the actual perspective of ultrasound imaging, there's always going to be limitations like how deep can the resolution go, or can you see past bone? Those kind of things. Are there artifacts? Just like in all radiology, is there artifacts in the imaging quality itself? Absolutely. But the biggest downside to MSK ultrasound or adding ultrasound to your practice is going to be both from a financial and time perspective.
Perfect. I appreciate that. I mean, we've got to look at things from both standpoints. From a patient standpoint, I don't see a real downside to it unless that there are the limitations in what can actually be seen. Can I see that posterior root? ACLs, for example, very challenging to see. So I do have to rely on the MRI for a lot of that. I can only do so much with the ultrasound, but in general, I like the physical exam, the history, the image, and together I get a pretty good picture. So it just means you might have to add one more variable.
Yeah, absolutely. No, that's the right approach right there.
Awesome. So Ryan, is there something that you'd like to say that we haven't addressed at this point, or some kind of a summary that you'd like to leave everybody with?
I think the biggest thing I'd love to leave people with is understanding that healthcare is changing. And it's changing at a rate that sometimes we can't catch up with. And so if we can have the tools and the communication skills to survive the changes of healthcare, whether it's from an insurance perspective or whatever it may be, social media has changed the landscape of everything that we're doing. Like, how do you get your information? The best thing that I can say that we may have missed is really taking the time to find out what your patients need. And if your patients need a new tool or a fancy new gadget or whatever it is, that's great. But just really make sure that whatever you're taking into consideration of adding to your practice or anything like that is make sure that the benefit of that at the end is your patient.
Love that. That's a great place to end with this portion, but people want to find you. How do we find you? How do we connect with you? How do we get into your course or just to follow and get some of this benefit from your online stuff? You're very active on LinkedIn. So what do you want to share? Plus it'll all be in the show notes if somebody's not available or driving and they can't take notes, but what are the assets you want to share?
Well, I guess I'm not hard to find. So I think the best way to find me is on LinkedIn. So it's just Ryan Martin, DPT, RMSK. I think that's somewhere around there. So it's just look for Ryan Martin and look for somebody who's doing ultrasound. That'll be me. But if you're looking for education resources, obviously I am biased on this. I feel that AMSKU, our website, it's the Advanced Musculoskeletal Ultrasound Center. That's our residency and our education platform. Spend some time there. But I also would love to just give a little shout to the fact that we're giving a ton of free webinars. We're giving away a lot of free ebooks and things like that to people who are interested, because it's not all about my partner and myself, Colin Rigney, about making the money. We need to keep a roof over our heads, but we've developed the concept is that we need to give away as much free resources, good quality resources, so people can actually grow and expand and understand the value of this. So if you go to my LinkedIn, you'll see that I'm giving away a ton of resources. And so I don't think because they're free, they're not valuable. Okay.
Oh, no. No. It's just your generosity and your ultimate goal. I think people get it from this. Your ultimate goal is the end beneficiary as a patient. So if that information, whether somebody paid for it or not, gets out there, the patient can only benefit. And I love that it's at your heart and your soul, Ryan.
It is. And I wouldn't be having this conversation with you if I didn't feel the same thing about you. So I feel that you're really out there for the benefit of the patient as well. And that's why I joined this YouTube. I love what you're doing. And I love the fact that you're promoting it with the YouTube and social media, and you're doing it the right way. So thank you so much.
It's my pleasure. Thank you so much. And we will catch you the next time. Bye-bye. If you have knee pain and would like to learn more, I have a worksheet called 5 Things to Do Now to Reduce Your Knee Pain Within a Week. Go to www.kneeboostnow.com to download it for free. I'd love to hear from you, so please like, subscribe, and comment below so I can help you get out of your knee pain.